Thank you, Brad. Thanks for having me here. I'm going to talk about one of the most exciting parts of medical deep learning imaging work is it's going to be on labeling. And that's something that I'm asked to do all the time, and it's something I can't say I look forward to doing. But unfortunately, it's necessary to some extent, so I work really hard in my lab to find ways so I don't have to do annotating myself, and we're going to talk about strategies for that. So when I look at a new project for deep learning in medical imaging, I think of the value of the label that we have. At the very top is ground truth, which is the least abundant, but certainly the best, and this is like a patient outcome or pathology. Somewhere in the middle are prospective annotations, and this includes the free text report, but also structured labels, as Kurt mentioned earlier, and even structured reporting. At the very bottom, and unfortunately what we're faced with the most, is trying to find a way to annotate images that were collected, but we don't have any other information. Here's an example of a ground truth project from Kristen Yom. She's a Stanford pediatric neuroradiologist. She has a data set of medulloblastomas on MR imaging that are tied to molecular subtypes. And so this is a tremendous database to either do radiomics work or deep learning work to try to predict non-invasively the molecular subtype of these tumors. Why is that important? Well, it turns out the molecular subtypes really tie well to prognosis and outcomes for these patients. So this would be an opportunity to potentially help the treatment outcome for these patients. So a great label and certainly an immediate impact. We have a lot of prospective structured labels at Stanford, as Kurt touched upon earlier. We use them for all kinds of different projects. It's very nice to have it. I like the saying that the best time to plant a tree is 20 years ago. The second best time is now. That's how we look at this program. We're so glad that it happened about 15 years ago because we have all of this data that's been labeled already. We use it for mainly deep learning worklist triage type projects. We have released it as a data set as well for a challenge in partnership with the Andrew Ng Lab, and you can go to the website and download that and use that for your own projects. But the thing that we have to deal with, of course, the most, unfortunately, is trying to assign a label to an image that has any number of potential labels, right? So this opacity in the right lung, that could be pneumonia, that could be cancer. We just don't have enough information. And it turns out that radiologists aren't really consistent. This is a study done about 8 or 9 years ago at the Brigham where they looked at abdominal CTs that a small group of radiologists had already read. They showed it to them a few months later, and they ended up disagreeing with their colleagues, which is no surprise, but then they disagree with themselves almost a third of the time, which is a little bit scary when we have people going back and annotating images for us. Another thing that can happen is you can have two imaging examinations that can have two correct labels. So these are two pediatric brain MRIs that are essentially identical, but one is normal and one has a severe neurologic disease known as Pelizaeus-Merzbacher, which causes a delay in myelination and causes the brain of a 3-year-old to look like the brain of a 3-month-old. So again, difficult to do these kinds of annotations without the context. So coming back to the idea of retrospective labeling, what we could use is the free text report. It's a little noisy, it's a little messy, and there's lots of different language variations that we use when we dictate. But if we can pull out the salient findings and we can describe the right label, we have an opportunity here to potentially scale and get me off the hook for having to label so much. So let's talk about the different labeling methods. Again, I looked at the world apparently in pyramids. I realized when I made this presentation, I'm not sure what that says about me, but when you go up towards the top of these different type of annotation methods, you have increasing noise. So the most scalable, but the most noise happens with simple search tools, and we'll touch on that. Somewhere in the middle are NLP techniques, and at the bottom is human annotation, so not very scalable, but certainly one of the most accurate ways to do things. Here's an advertisement looking for radiologists to annotate medical images. This is from Analytic. Unfortunately, in my lab, we don't have the budget to hire a lot of radiologists to do this, so we have to look for other opportunities to do our labeling. Search tools is one way. I know Kurt, again, mentioned this earlier. You can search with certain terms, but with every term that you add on, you're going to add more noise. So if you're looking for pulmonary embolism, you can search PE embolism, thromboembolism, but with each term, you're going to sort of catch more studies that have the wrong diagnosis, and so you're going to have a second step in order to sort of secondarily curate that. So we spend a lot of time with machine learning. This is work we did a while ago. We've since moved away from this, but for the point of discussion, we use support vector machines to classify free text NEMRI reports from 2 institutions. This was a binary classification task, so looking for surgically important lesions from NEMRIs. SVMs are a little bit unwieldy. They take a little bit more engineering know-how to use. Our results were okay. This is just a snippet from our paper, just to give you a sense that they can be accurate, but certainly carry with them some noise, and they aren't as generalizable as we'd hoped. They're also, you have to choose the kernel, you have to deal with regularization penalties, you have to deal with the slack variable, so there's all kinds of problems with support vector machines that have caused us to sort of switch towards deep learning for NLP. We find that the deep learning techniques have performed as well or better in most cases, and they tend to generalize pretty well on external report data sets, and I'll show you an example of that. So here's a figure from our paper in radiology. When we sort of talked, again, as Brad mentioned, we were going to show some visualization examples. So this is a relatively shallow CNN. We used a pre-trained word vectors and glove embeddings to create a classifier that can pull positive PE from free text CTA reports. And you can see, we didn't do any word level annotation, by the way, for the training data. This is all document level. And yet the CNN model was able to identify the words that you would expect it to in order to come up with the diagnosis of PE. So that was reassuring. On the right-hand panel, those are just our area under the curve for PE positive and PE acute labels. We call this project our kitchen sink, or the Avengers project, because we decided just to take every classifier method we could and throw them into one paper. We used 500,000 reports from 4 institutions, and this was done in collaboration with Philips Healthcare. And we kind of sat down and said, could we build a deep learning classifier for NLP that at least matches what the report structure looks like for radiology reports? And so to do that, we did some end-to-end LSTM layers to have some word representation built in, as well as sentence representation built in, then passing that finally through a softmax layer. And on the left-hand panel here, this is another visualization map. This is one where that CNN model I showed you earlier got it wrong, but this new method got it right. The word level dependencies are in green, and the sentence level dependencies are highlighted in blue. And you can see that in sentence 3, the distance between no and embolism is kind of long. And so you can see why maybe the CNN model may not have picked that up. But by sort of maintaining that sentence level weighting, we could see that sentence ended up being, or those words ended up being significant for our second classifier. The results are on the right. This was trained on 4,000 document level labeled PE studies that we had humans do, and we can see that the results were pretty good across the board compared to our other classifiers. When we try to generalize to a Duke data set, their reports are not quite as structured as ours, and so we found that the performance did lag a bit. But I think the take-home message for us was just that we know we're going to have some noise when we do this, but if we can do this at scale, maybe we can get away with it. And so let's talk about quantity and quality. When we talk about how much training data we really need and how important noise is, we kind of look to the ImageNet community, the machine vision community, because they've done a lot of this kind of work. And this is a great paper out of the group from MIT and Cornell, where they looked at purposely putting noise into their data sets to see how it affected their classifier. And you can see that at 2-to-1, 3-to-1, even 5-to-1 noise, the performance doesn't dip that much. I mean, it's down, but it's not as much as you'd expect if you have 5-to-1 noisy labels to accurate labels. So this was encouraging to us. Kurt kind of showed this data in a different way earlier, but this is work from Nigam Shah's group out of Stanford, where he has many different EMR classifiers that can predict diabetes or heart attack. And what he wanted to know was how much noise could he put in his data set before his classifier performance went down, and if it did go down, how could he bring it back up to the 100% accuracy level? So again, as Kurt sort of mentioned, there's a relationship between noisy data and the amount of data that you have to overcome that. This is some very recent work from us. We have 200,000 chest x-rays that were labeled as normal or abnormal in our archive. We use these to train classifiers, and this is a classifier that was trained, and both of these curves represent the same training data, but 2 different test sets. So the dotted line, the lower performance, is a test set of the holdout baseline training labels. So we know there's some noise in there, right? 10 to 15% noise by our estimation. But when we took that same test set, and we actually relabeled it with a panel of experts, we took out the noise. And just by doing that, nothing else, our performance went from a 0.89 area in the curve to a 0.96. That's pretty significant, because a lot of the tradition in the machine learning community is just to take a holdout of your training labels and test your model on that, and that's your performance. And so that was actually our experience when we did this work with Andrew Ng on ChexNet. When we used the NIH data set, which has been criticized as being noisy, we didn't find it to be that bad. And the reason we didn't have the same performance problems is I think that we had an expert-labeled test set that we used to demonstrate our performance. And when we compared against 12 practicing radiologists on the same test set, we found that our classifier, again, trained on this noisy data, did just about as well as they did. And so we know that we can use noisy labeling data to create accurate classifiers if we have the right principles in place. All right. So in conclusion, medical data is messy, as I mentioned. I talked about label value hierarchies. You can use data volume to overcome data noise, and I think that's important to know. And then, of course, accurate test set labels are very important. And that's all I have. Thank you.